This training video is sponsored by the Tennessee Department of Mental Health and Substance Abuse Services in partnership with the Tennessee Association of Mental Health Organizations, TAMHO. Funding was provided in part under Grant Number 6 H79SM086148, the Substance Abuse and Mental Health Services Administration, SAMHSA, the U.S. Department of Health and Human Services, HHS. The views, policies, and opinions expressed are those of the authors and do not necessarily reflect those of SAMHSA or HHS. This learning series is entitled Comorbidity and Youth at Clinical High Risk for Psychosis. This presentation explores the relation between clinical high-risk CHR for psychosis and common comorbid conditions such as depression, anxiety, trauma, and substance use. It examines how these comorbidities influence symptom, severity, diagnosis, and treatment approaches, highlighting the importance of comprehensive assessment and individualized care. Research findings and clinical considerations are discussed to improve understanding and intervention strategies. Learning objectives include 1. Identify common comorbid conditions associated with clinical high risk, CHR, for psychosis, and be familiar with their prevalence based on research findings. 2. Differentiate between primary psychotic symptoms and symptoms influenced by comorbid conditions such as anxiety, depression, trauma, and substance use. And 3. Explain how comorbid conditions impact symptom severity, functional outcomes, and treatment approaches in individuals at CHR for psychosis. Presenting this topic is Dr. Jason Schiffman. Jason Schiffman, a professor at the University of California, Irvine, earned his PhD in clinical psychology from USC. His research advances the identification and treatment of individuals at risk for psychosis, focusing on refining diagnostics, implementing psychosocial interventions, reducing stigma, and promoting health for all. With over 200 publications, he has secured over $20 million in funding, including several active NIMH grants involving individuals at clinical high risk, CHR, for psychosis. Dr. Schiffman co-founded 3 university community partnerships, including a SAMHSA-funded CHRP program, and is among the few certified trainers of the structured interview for psychosis risk syndromes. He also consults for CHRP programs nationwide. Join me in welcoming Dr. Jason Schiffman.
Hi, my name is Jason Schiffman, and I'm a professor in the Department of Psychology at the University of California at Irvine. And today I'm going to be talking about comorbidity and CHR, or clinical high risk for psychosis. All right, I got an ambitious agenda for us today. First, an overview of psychosis, clinical high risk for psychosis, diagnoses in general, and what comorbidity means. Then I want to spend a few minutes emphasizing the point, like why this is important and what we should really be thinking about to best support the folks that we're working with. I have a few studies from my research program that I thought might be interesting to share with y'all. Then I'll get into some specific recommendations for ways in which we can differentially diagnose or parse apart risk for psychosis from other mental health concerns. Hopefully we'll have time to talk about a clinical vignette or an exercise that can breathe some life into this. And then I'll briefly end with a few ideas that pertain to treatment implications. So without further ado, let's jump right in. I want to start with an overview. Overview where I'll briefly cover psychosis and some of its impacts on clinical functioning. To give you a broader sense of like the diagnosis as well as comorbidity, which is ultimately the main topic for today. Before delving into studies, I think it's important to discuss the real-life effects of schizophrenia and psychosis on individuals with these challenges. Schizophrenia is perhaps the most debilitating and potentially devastating mental health condition. It can be distressing and destructive for patients as well as loved ones. Its impact is widespread, occurring in nearly 1% of the population and impacting approximately 2 million adults in the US. This equates to about 100,000 young adults developing a first episode of psychosis annually. These disorders impact independent functioning and quality of life, and impact not just the identified client, but family members and loved ones as well. I will say this, however, although there are negative outcomes often associated with psychosis, it's important to keep in mind that many individuals who experience psychosis can and do lead full and successful lives of their choosing, and lives in the community. We call this recovery, and we should be thinking about recovery as the expectation and not the exception. Additionally, many individuals who experience psychosis report positive changes as a result of their experiences that provide them purpose and meaning. And one of the best ways to potentiate recovery is through early intervention predicated on early identification. Okay, so what are diagnoses? What is comorbidity? And that's sort of the topic of this. Now, a mental health diagnosis is a tool used to categorize and describe patterns of thoughts, emotions, and behaviors that significantly impact an individual's functioning or well-being. It provides a shared language for clinicians, researchers, and patients, hopefully helping to guide treatment and improve communication about care. Diagnoses can help people understand what they're going through, make symptoms clearer, and importantly, connect them with the right resources and treatments. But it's important to think about these labels very carefully. While they can be useful for organizing care as well as research, they sometimes simplify complex experiences, create stigma, or miss the way mental health issues can overlap and change. For instance, people at high risk for psychosis often deal with other issues like anxiety or depression, which can cause a lot of stress. This mix can make it tricky to figure out what the main problem is, whether it's the risk of psychosis, other concerns or conditions, or how they all interact. Ultimately, while diagnoses are helpful frameworks, they are not the full story. They offer a way to look at mental health, but they shouldn't be the only thing that defines someone or their treatment. What we really want is a well-rounded approach that takes into account each person's unique experiences and background, along with any other mental health issues they might have. This is especially important when we're working with complex contexts and situations, like those who might be at risk for psychosis. I'm highlighting here the prevalence of co-occurring conditions reported in the Naples 2 project, one of the largest clinical high risk for psychosis studies, as well as some other research here as well. But about almost 80% of individuals at CHR have at least one other diagnosis, illustrating how common comorbidity is among people at clinical high risk for psychosis. Depression is particularly prevalent, affecting 40 to 60%, while anxiety disorders, primarily social anxiety and generalized anxiety disorder, present in about 25 to close to 50 or a little over 50%. Bipolar disorder, a little less common, but about 7%. Trauma is another major contributor and coexisting experience, with approximately 80% of people at risk for psychosis reporting a history of trauma, and anywhere between 3 and 14% meeting criteria for PTSD. Dissociative disorders, though well documented in psychosis, they're less studied in CHRP populations, but they're probably relevant as well. And substance abuse comes up quite a bit, with 11% reporting general substance use and 13 specifically reporting cannabis use, which can exacerbate or potentiate symptoms. The role of comorbidity in those at clinical high risk for psychosis, it's complicated. It's not always clear whether being at CHR increases the risk for developing other mental health disorders, or if these other disorders increase the risk of being at CHR, or perhaps both processes are occurring at the same time. Psychotic symptoms often emerge in the context of other clinical disorders beyond schizophrenia spectrum considered disorders. For instance, major depressive disorder with psychotic features is considered a marker of increased severity. This highlights the need to understand psychotic symptoms not in isolation, but as part of a broader clinical picture. Interestingly, a review by, I think it was Beck et al. In 2019 suggests that addressing a primary disorder such as anxiety or depression could lead to remission or improvement of CHRP symptoms. Research also indicates that the majority of individuals who eventually develop psychosis initially seek treatment for non-psychosis related issues, such as depression or anxiety, well before their psychotic symptoms were even diagnosable. So taken together, you can see the importance of addressing comorbidities in clinical high-risk populations. Uh, when we take these steps, we're not just helping with mental health overall, we might also keep things from getting worse or even stop someone from preventing threshold psychosis. Okay, so you see here a variety of different signs that I have here, signs of clinical high risk for psychosis, from withdrawal to social difficulties, unusual behavior, falling asleep in class, sadness, excessive anxiety, absenteeism, poor concentration, spacing out, hypervigilance, becoming neglectful and unfeeling. These challenges are quite common and are not specific indicators of psychosis. I wouldn't predict that someone who experiences one or even all of these challenges would necessarily be at risk for psychosis. However, having just one of these challenges may warrant further assessment to understand the context behind the concern. It's important to explore what is driving the concern, the challenge here. While these factors do not necessarily suggest that psychosis is on the horizon, they do suggest a need for a closer look to determine if additional evaluation or support might be helpful. Now, this slide focuses on behaviors that may be more suggestive of early psychosis, but it's really important to recognize that these signs can also have alternative explanations and require context for accurate interpretation. Emotional outbursts could reflect psychosis, where emotional regulation becomes disrupted, or they could indicate depression, anxiety, or even a response to trauma. Withdrawal from friends or family could signal social disconnection due to psychosis or paranoia, or it might also stem from depression, social anxiety, or interpersonal conflict, for example. Poor personal hygiene might reflect the functional decline associated with psychosis, but could also be a sign of depression, neglect, or even a lack of resources or knowledge about self-care. Odd thinking or behavior might point to emerging psychotic symptoms such as delusions, but they could also reflect cultural or contextual or developmental differences, ADHD, or even creative thinking that's taken out of context. While paranoia or suspiciousness is a hallmark of psychosis, mistrust could also arise from real-life experiences like bullying, trauma, or strained relations. Perceptual disturbances. They might suggest psychosis, but they could also be linked to stress, to substance use, migraines, or even sleep deprivation. The key takeaway here is that while these behaviors can raise concern for psychosis, they're not unique to it. It's really important to take a good look at the whole picture, including the background, history, and any other diagnoses to figure out what's going on and what the best solutions might ultimately be. When identifying psychosis, behaviors are important, but context just as important for making clinical and diagnostic decisions. Here, I try to highlight key factors to consider alongside observed behaviors. First, recency of change. This is important. Have these behaviors emerged suddenly or evolved over time? Sudden changes may signal a change suggestive of psychosis versus something that's developmentally more stable. Next, understanding the full picture of experiences is important as well. Really listen to learn more. We also should consider the level of distress. Are these behaviors causing significant emotional discomfort? If so, what's driving that? Finally, consider the interference with functioning. Are these behaviors impacting school, work, relationships, or daily activities? Functional impairment helps us tell apart real clinical issues from everyday behavior change. By keeping this in mind, we can more effectively assess and understand concerning behaviors, making sure that we're on point with our evaluations as well as ultimately our interventions. Okay, now we're going to switch gears to understanding the root or the point of all this, the real point, the point really that gets to the heart of what we've been discussing so far and what we're going to continue, is how understanding the underlying factors behind behaviors or symptoms allows us to make better clinical decisions and improve outcomes. If someone is presenting with social withdrawal, is it due to paranoia linked to psychosis, or could it stem from social anxiety or maybe bullying? Without understanding the root cause, we risk treating the symptom in isolation and potentially missing the larger issue. Similarly, recognizing the role of trauma is essential. Trauma doesn't just contribute to emotional distress, it can fundamentally shape the way someone interprets and interacts with the world, including the development of psychotic symptoms. Tailoring interventions to address trauma as a root factor can lead to meaningful improvement in functioning and well-being. Even when it comes to substance use, such as cannabis, the root might be coping with anxiety, boredom, or peer pressure, for instance, but the end result might be full psychosis. Without addressing the why, treatment efforts may fall short. So ultimately, the idea reminds us to go beyond surface level observation. When we deeply understand the origins of a behavior or a symptom, whether it's neurobiological, social, or psychological, or elsewise, we can come up with treatment plans that are not just effective, but also caring and really connected to what each person has been through in their life and what they want to prioritize. All right, so what's the root of the issue? What's really going on? This slide is common sense in a way, but it illustrates how we can take for granted what a client is interpreting, or how a client is interpreting a question. And if they're interpreting it the same way it's intended to be understood by the assessor. So if we stop and ask something like, tell me more about that, to any of these questions, we come to the right conclusions. This is more obvious when interviewing and talking, but it's less so when interpreting self-report assessments. So if you're doing screening and you don't have a chance to have a conversation, then you might sort of lose sight of these things. But if you're doing an assessment and you're talking and having a conversation with a young person, and you ask them a question like, do you ever think that people might be able to read your mind? And then say, tell me more about that. And they say, yeah, my best friend is exactly what I'm thinking. This is about their connection with their friend and not about mind reading, for instance, or eyes playing tricks on you, a common symptom in psychosis risk evaluations. But if you don't ask for a follow-up, tell me more about this, you might lose, no pun intended, sight that the person in this case was just having problems with their contacts. Sometimes I forget to put my contacts in and everything's all out of focus. Do you ever feel that people around you are thinking about you in a negative way? I'm so paranoid that they're judging me because of my weight. She uses the word paranoid, but this is not really in the context of suspiciousness, psychosis, risk, paranoia. This is more in the context of social evaluation, social anxiety. So, do the experiences meet the essence of clinical high risk for psychosis or not? And asking good follow-up questions gets us to the root of the concern. These three different examples will lead you to different conclusions in treatment. The first might have you target a spectrum of social anxiety towards paranoia and prompt you to understand the distinction of the client more over time. So having severe paranoia regarding evaluations, social anxiety, and feeling like someone is plotting against them. The unrelated example, the second one, intrusive thoughts and compulsive behaviors regarding hand washing and seeing shadows of the corner of their eye. The unrelated example might have you targeting both separately while trying to decide with your client which to prioritize first. And the third example, feelings of hopelessness leading to preoccupying fantasies that the world was no longer real. If the hopelessness faded, the clinical high risk for psychosis related symptoms might be primary. However, if hopelessness seems to be feeding the fantasies, then you approach things maybe differently. So these are just some examples, but every situation is unique, with the key being to figure out what's most important for the client and what is the real issue underneath things. There can be different pathways to this stuff. These pathways emphasize the interconnectedness of mental health conditions, and the importance of understanding individual experiences. One possible path is that anxiety can lead to depression, which then develops into a clinical high risk for psychosis diagnosis. For some people, constantly worrying might turn into feelings of sadness or hopelessness, eventually, maybe mixing in with some psychosis like symptoms. On the flip side, you might start with clinical high risk for psychosis, which can lead to anxiety and then to depression. The unusual thoughts or increased suspicion, for instance, can create a lot of emotional stress and seriously affect a person's mood. Trauma plays a significant role as well. And evidence supports a dose response relationship here. The more trauma an individual experiences, the more likely they are to exhibit clinical high risk symptoms. This underscores the importance of addressing trauma in our clinical work. Substance use is another key factor. Substances can serve as a form of self-medication for anxiety or distress or something like that, but can also act as a trigger for worsening symptoms of psychosis. In the Naples 2 study, the large clinical high risk for psychosis study I mentioned earlier, substances were the only comorbidity shown to increase the likelihood of conversion to psychosis. Ultimately, while we may never fully understand the precise pathways for any given individual, what matters most is working with the issues at hand, whether they're their anxiety, trauma, substance use, or something else. To reduce distress, improve functioning, and address symptoms as they appear, work with the challenges that the client brings forth. So shared decision making and client and family driven. I'm going to revisit this at the end, but I do like to make the point that all folks are far more similar than they are different, irrespective of their status related to psychosis. Given that that is a truth, and it's true for our clients, the tools that we use to help our clients without psychosis risk are likely going to be useful for helping our clients with psychosis risk. So comorbidity allows us to use those tools to work on some of those challenges. Again, more on that later on. But now I think I want to shift gears and talk about a few research studies from my research team, just briefly. Here, so some comorbidity studies here. I will say this, clinical high risk research, it often relies on healthy controls or people that don't have mental health concerns to study the psychosis risk. So there's a contrast group. Now, this approach has been foundational, but it comes with significant limitations. As we've been discussing, many at clinical high risk present with comorbid conditions, which are by definition absent in typically functioning controls. And this creates challenges in distinguishing which findings are truly related to psychosis risk versus related to general psychopathology. In this paper, if you're interested, we make the case that by comparing folks at clinical high risk to both healthy or typically functioning controls and help-seeking controls, those receiving mental health services for another mental health concern, we can better isolate the unique features of psychosis risk, refine our predictive measures, and enhance the clinical utility of our findings towards better treatment planning. In this early study, consistent with the study prior where I talked about the value of help-seeking controls to really parse out the impact of clinical high risk versus comorbidity, we wanted to distinguish clinical high risk from other mental health concerns based on how people report their symptoms. So we gave a group of young help-seeking people, some with clinical high risk for psychosis, some not, the BASC-2, which is a checklist for mental health concerns. And what we found was global impairment across the board relative to the general population. But we also found some specific differences between our sample of help seekers, some with CHR and some without. Specifically, some of the biggest effects were seen in depression, attention, and sense of inadequacy, with our folks at clinical high risk scoring higher on these, even relative to people receiving mental health concerns for other problems. Additionally, youth at clinical high risk, they struggled more in terms of adaptive functioning and resilience, and in their relationship with their parents relative to youth with other mental health concerns. I think this study highlights some of the interesting symptom patterns in people at clinical high risk, but it's not just the usual clinical high risk symptoms. It's what goes above and beyond other mental health concerns. A lot of these symptoms are also common in young people in general, which means that there are already some treatments out there that could help these young people at risk for psychosis. Thinking of or conceptualizing suicidality as a comorbid consideration, in this study, we showed that all subtypes of risk symptoms, including delusional mood, suspiciousness, thought possession, and hallucinatory experiences, all of these were associated with higher odds of suicidality, and also hallucinatory experiences being the most prominent of those. Now, this finding, it indicated a dose-response relation where the odds of suicide risk as an outcome increased with the number of risk factors for psychosis, the number of items endorsed with respect to psychosis. In other words, the more psychosis risk symptoms, the more likely the comorbid concern of suicidality is to emerge. Social anxiety disorder, or SAD, is common in individuals at clinical high risk for psychosis, but its impact on symptoms and functioning has been underexplored. In this study, we used a community-based sample to examine the prevalence of SAD in clinical high risk for psychosis populations and its relation to psychosis symptoms and social functioning. What the team found was that 42% of those at clinical high risk met criteria for SAD compared to only 13% in the control group. Importantly, increased social anxiety was strongly associated with poor social functioning. Ultimately, these results show that social anxiety plays a big role for a lot of people at clinical high risk, and it points to it as something we could focus on in interventions for those folks that it is impacting. We conducted another study, this time with kids on the autism spectrum. Ultimately, what we found here was that the tools we use to identify risk for psychosis, they actually can be useful for kids on the autism spectrum. But you have to be careful with the interpretation of endorsements to questions. You can see here on this slide prompts from the psychosis risk assessment questions being answered truthfully, but for different reasons by our kids with autism. Making sure there's a shared understanding of the questions is key to disentangling all sorts of different things. Like, for instance, have you ever had the feeling that something odd is going on or that something is wrong that you can't explain? This is a question from our assessment tool to identify risk for psychosis or clinical high risk for psychosis. And then you can see that our client here with autism answered, I'm very interested in subway maps, and my sister says I'm weird. So they're answering truthfully, but there's a disjoint between how the question was intended to assess for psychosis risk and how it was interpreted in terms of their experiences of being on the autism spectrum and associated characteristics there by this young person. In terms of tolerability of the gold standard interview for risk for psychosis, what we found in our study was that participants on the autism spectrum disorder, they had a harder time with the instructions and the interview. The interviews tended to take longer, but the youth with autism spectrum disorder, with a little bit of patience from the assessor as well as from the youth themselves, they could get through the interview and they could understand things just as well as other folks. Just takes a little extra time. All right, in this study, we looked at how COVID-19 infections might be connected to psychotic experiences. This one is particularly among college students. But here we wanted to see if COVID could be linked to psychosis as a physical health issue. Using data from the Healthy Mind study with over 15,000 students, this was between September and December of 2020, excuse me, we discovered that students who had COVID were 36% more likely to report experiencing psychotic symptoms. But when we considered anxiety and depression, that connection didn't seem to hold anymore. So what we concluded and what this suggests is that the link we noticed might actually be tied to the overall mental health effects of the pandemic instead of, in this case, a direct effect of the virus on the brain leading to psychosis risk or psychosis continuum symptoms. All right, the last study that I want to mention before we move on is this one about categories versus continuum. So like most disorders, early psychosis, risk for psychosis traditionally has been understood through a categorical model, models that place individuals into fixed groups like low risk, clinical high risk, or psychotic disorder. Now, we wanted to challenge that approach a little bit, thinking maybe a dimensional model that evaluates psychosis on a continuum based on symptom severity may be more effective. So we discovered through this work that looking at symptom severity on a scale gave us a clearer picture of how people function socially and in their daily roles, rather than just relying on strict categories of risk or not risk. It's interesting to note that there's a lot of overlap in symptoms between different groups, which highlights the downsides of sticking to rigid classifications. In other words, there is comorbidity and different people have lots of different symptoms. The main takeaway is pretty simple. Using a dimensional approach can give us a deeper insight into psychosis and help design more personalized treatments. This kind of flexible thinking offers a better way to understand and address early signs of psychosis. Like most disorders, early psychosis is traditionally understood through a categorical model that places individuals into fixed groups like low risk, clinical high risk for psychosis, or having threshold psychosis. We wanted to challenge that approach in this work, thinking maybe a dimensional model that evaluates psychosis on a continuum based on symptom severity may be more effective. We discovered that looking at symptom severity on a scale gave us a clearer picture of how people function socially and in their daily roles, rather than just relying on strict categories of risk. It's interesting to note that there's a lot of overlap in symptoms between different groups, which highlights the downsides of sticking to rigid classifications. The main takeaway is pretty simple. Using a dimensional approach can give us deeper insights into psychosis and help design more personalized treatments. This kind of flexible thinking offers a better way to understand and address early signs of psychosis. Okay, so now I want to get into some specific recommendations. Now, I'm going to go through common diagnoses that overlap with CHR. The point here isn't necessarily to be able to say that they have one diagnosis or over another diagnosis, but rather to highlight questions that will help you get a better sense of what might be driving the underlying challenge, which I think in the end is what we're really after. OCD and CHR can both involve intrusive thoughts and heightened distress, making differentiation sometimes challenging. In OCD, the intrusive thoughts typically conflict with the person's self-image or beliefs and are accompanied by compulsive behaviors aimed at reducing anxiety. In contrast, CHR more likely involves thoughts with a delusional or bizarre-like quality, maybe, for instance, with suspiciousness or paranoid ideations, and these thoughts are perceived as real. Asking whether the individual recognizes their thoughts as irrational can help clarify the diagnostic differentiation here. I talked about this a little earlier in our own work, but autism spectrum disorders and clinical high risk for psychosis share features like social withdrawal and rigid thinking, among others. However, the timeline of symptom development is really key here. Autism spectrum disorder symptoms typically emerge in early childhood and are consistent over time, involving social communication deficits, as well as repetitive behaviors in many cases. Clinical high risk, on the other hand, often involves a recent decline in functioning, coupled with delusional or perceptual disturbances that are inconsistent with how things once were in childhood. Understanding the developmental trajectory is probably most important for accurate diagnoses, but also bear in mind that these diagnoses are by no means mutually exclusive. At least 10% of adolescents with autism have some symptoms of psychosis. While both CHR and depression can share symptoms such as sadness or low mood, reduced energy or motivation, and social withdrawal, the underlying causes and additional features are often different. For individuals at CHR, you might see blunted or flat affect, along with unusual thought content or perceptual change that are unrelated to mood. In contrast, depression is more likely to present with persistent sadness, guilt, or hopelessness, often tied to specific life stressors and accompanied by somatic symptoms such as changes in appetite or sleep patterns. The key question we should ask are the symptoms reflective of mood dysregulation, or are they indicative of broader cognitive or perceptual changes? Of course, it's important to remember that having CHR can lead to depression and probably vice versa as well. So bear all of these factors in mind. All right, CHR and bipolar both can involve grandiosity, periods of high energy or agitation, and unusual or erratic behavior, making differentiation challenging here as well. In CHR, we often see unusual thought content, perceptual changes, or paranoia that aren't clearly tied to mood episodes. These symptoms might suggest early psychosis risk rather than a mood disorder related to bipolar. In bipolar disorder, symptoms are more closely linked to distinct mood episodes, such as mania, characterized by increased energy, reduced need for sleep, and often an inflated sense of self or self-esteem, or even depression marked by low mood and decreased activity. A key question here, are the symptoms linked to distinct mood episodes, or do they suggest broader cognitive or perceptual disturbances? I tell you, this one can be particularly tricky as these two can go hand in hand, and grandiosity is very much associated with both. All right, CHR and PTSD. Here we get into the essentialness of trauma-informed care. PTSD and CHR share symptoms like hypervigilance, difficulty distinguishing reality, particularly during flashbacks and PTSD. The key differentiator here, oftentimes, but not always, is the connection to trauma. PTSD symptoms are clearly linked to a traumatic event and often include avoidance behaviors and re-experiencing the trauma through flashbacks or nightmares. In contrast, CHR generally involves broader perceptual changes, unusual thought content, or suspiciousness that are not specifically or necessarily tied to specific traumatic experiences. You won't always have access to all the information you need, but exploring the context and triggers of symptoms can guide the diagnosis. But here it's particularly important to be mindful of the fact that trauma in some cases can lead to psychosis. So really understanding what the client is going through and experiencing and has experienced, what's happened to them in the past, can really play a big role in successful differentiation and conceptualization here. CHR and dissociative identity disorder are often a question. Now, both conditions can involve disconnection from reality, difficulty distinguishing internal versus external stimuli, and voices or auditory phenomenon. These shared features can really make differentiation a challenge. However, there are some notable differences. In dissociation, symptoms are often autobiographical and usually linked to trauma. Additionally, amnesia or memory gaps are more frequent in DID, reflecting what people in that area sometimes refer to as identity fragmentation, which isn't as common in CHR. In CHR, voices, they typically emerge later and are not necessarily tied to trauma, although they could be, at least not directly, or the nature of them isn't necessarily immediately linked. So As we've been discussing, CHR symptoms tend to be more like paranoia, unusual thought content, or something similar, differentiating them a little more from DID. A key question here to consider is, are these experiences rooted in trauma and identity fragmentation, or do they reflect broader psychotic processes? Substance-induced psychosis and primary psychosis can look very similar. Both may involve hallucinations, delusions, or disorganized thinking. The difference oftentimes lies in the details. First, timing. Substance-induced symptoms usually start during or soon after use, while primary psychosis tends to develop on its own. Second, resolution. In substance-induced cases, symptoms often fade fairly quickly once the drug wears off. In primary psychosis, symptoms persist beyond the immediate effects. Third is severity and duration. Substance-induced episodes, they're often shorter and more variable. Primary psychosis, more stable and enduring. Fourth, we have history. If symptoms consistently follow substance use, that's a clue towards a substance-induced cause. Fifth is abstinence. After a sustained period without substance use, symptom improvement suggests a substance-induced origin. Persistence, despite abstinence, points towards primary psychosis. I got a sixth one here, symptom type. Certain drugs are linked with specific symptom patterns, like paranoia with stimulants or perceptual changes with hallucinogens. And finally, some associated symptoms. Intoxication or withdrawal signs point towards a substance-induced origin, while negative symptoms or chronic disorganization tends to fit more parsimoniously with primary psychosis. I compared substance/medication-induced psychotic disorder and schizophreniform disorder in this slide because their similarities can complicate diagnosis and treatment, and I thought it would be illustrative to spend a moment on this. Now here you see substance-induced psychosis is linked to external factors like substance use, while schizophreniform reflects an internal psychotic process. Here are four key differences. One is timing. Substance-induced symptoms are connected to substance use or withdrawal. Schizophreniform symptoms are independent. Duration. Substance-induced symptoms resolve quickly post-substance clearance, while schizophreniform symptoms last 1 to 6 months. And the next one is cause. Substance-induced is caused by substances. Schizophreniform arises generally from internal processes that we might not have a clear perspective on. And then negative symptoms. These negative symptoms, like flat affect, they're common in schizophreniform, but less so in substance-induced. So just a little example to further clarify substance use and schizophrenia spectrum disorders in general. All right, this one's sort of interesting in the space of clinical high risk for psychosis versus full threshold psychosis. Now, CHR represents an early phase of psychosis with subthreshold symptoms. Individuals with CHR often retain insight into their experiences, recognizing them as unusual, and exhibit milder functional impairment. First episode psychosis, on the other hand, involves threshold symptoms like clear hallucinations or delusions with significant functional deterioration. Assessing symptom severity and the individual's insight into their experiences is key to differentiating CHR from FEP, or first episode psychosis. That level of severity plays a big role in parsing out very severe and significant clinical high risk for psychosis from full threshold psychosis. I want to make a pitch for a transdiagnostic approach. A transdiagnostic approach shifts the focus from rigid diagnostic categories to shared underlying processes. This is more akin to the paper I mentioned we wrote on continuums versus categories. This perspective is particularly helpful when distinguishing CHR from overlapping conditions like OCD or autism spectrum disorders, PTSD, and even full threshold psychosis, all of which often share symptoms such as intrusive thoughts or social withdrawal or hypervigilance. But by understanding the common mechanisms, such as, let's say, cognitive biases or heightened stress reactivity, mental health professionals can better tailor interventions to individual needs, moving beyond the constraints of a single diagnosis framework. This approach promotes holistic and personalized care. Now, this is a segue into how we recommend approaching care and treatment for this population. Which brings us to our next section around clinical exercise here. Now, I have a few vignettes I thought I'd share with you that illustrate some of the issues we've been talking about through our time together today. Okay, so this is a vignette of an individual named John, and John reported experiencing multiple people in his head, each with distinct voices and the ability to control his thoughts and behavior. He referred to the most prominent one as his imaginary friend, present since he was 3 or 4 years old. This persona often takes over during stress, pursuing different goals, but generally leading to positive outcomes, which John finds confusing and distressing. He described episodes where he feels like a figment of his own imagination while the people feel real. These episodes occur several times a week and can last for hours, especially when the imaginary friend is in control, diminishing his reality and identity. He attributes these experiences to childhood sexual abuse, suggesting that he has compartmentalized the trauma into this persona, which displays behaviors contrasting with his own. Despite the distress, he believes strongly in the reality of his imaginary friend during these episodes and feels uncertain about challenging this belief. He demonstrates insight by linking these experiences to his trauma, viewing them as part of his coping mechanism. Okay, so this vignette suggests dissociative identity disorder over clinical high risk for psychosis based on the key features that are described here. The participant, John, he describes distinct people in his head, each with their own voices and control, which aligns with dissociative identity coping mechanisms for trauma, particularly, and not always, but in many cases, childhood abuse. Unlike CHR, where symptoms include unusual thought content and lack of insight, John shows significant awareness of his experiences as linked to his past trauma. His episodes of feeling like a figment of his imagination, along with the compartmentalization of traumatic experiences into altered identities, further indicates DID over CHR or psychosis risk. Of course, there could be overlap, and these concerns aren't mutually exclusive, but it seems like the preponderance of evidence in this case for John suggests DID over CHR. All right, now let's look at a different one. In this case, still talking about John, but let's imagine a different John. John described experiencing multiple voices in his head, each telling him different things and sometimes influencing his thoughts and behavior. One occasionally pushes him towards action that feels inconsistent with his usual behavior. While they don't happen that often, maybe a few times per month and only briefly, and they didn't start until he was a teenager, these episodes are confusing and distressing, particularly when he worries that what will happen if he doesn't do what the voices tell him to do. John also reported episodes where he feels unreal, while the voice feels more real than himself. These episodes have increased in frequency and duration over the past year without a precipitating incident. He explained that these experiences make him question his sense of self, particularly when the voice influences his behavior, adding to his distress. He isn't completely convinced the voices are real, and he primarily views them as unusual and outside of his control. Okay, in this version of John, in contrast, this is more CHR than dissociative identity disorder. John hears distinct voices that influence his behavior, which aligns more with CHR, as these voices feel separate from him, but aren't fully formed identities like in DID. Additionally, the emergence of these voices during adolescence hints at CHR, as opposed to a coping mechanism or some reaction to childhood events or trauma. John's feeling of detachment and questioning his reality are also, in this case, more signs of psychosis risk suggesting disruptions in self-perception, typical of CHR rather than trauma processing, often seen in DID. While he connects his experiences to past stress, he doesn't share the autobiographical traumatic details characteristic of DID. His unusual thought content and altered perceptions suggest a potential progression towards psychosis rather than dissociation and dissociative coping mechanisms. Let's do another. This one is about Jackie, and the overlap here is around autism. So Jackie reports increased sensitivity to noise over the past 2 to 3 months, noting discomfort from low sounds like a refrigerator humming and loud noises. They brought noise reduction earplugs to help, experiencing sound sensitivity 4 to 6 times a week for a few hours. While bothersome, it doesn't affect their functioning when using earplugs. They attribute this sensitivity to neurodivergence, possibly ADHD or autism, and mention experiencing ringing and buzzing in their ears every couple of months. Jackie's symptoms, especially the sensitivity to everyday sounds and their use of earplugs to manage it, not a symptom but a coping mechanism, are more consistent with autism than CHR. The experiences are sensory based, not perceptual distortions or unusual beliefs, as you might see in psychosis. Jackie also shows insight and attributes their symptoms to possible neurodivergence like autism or ADHD and not psychosis. So Jackie is, as all of our clients are the experts on themselves. Now in CHR, we'd expect more distress, confusion, functional or impairment as well. All of these things can be linked to emerging psychotic symptoms, which isn't the case here. The one thing I'd probe a little bit more on is when Jackie says that the sensitivity to noise has emerged increasingly over the last 2 to 3 months. I'd be curious to see how it was like beforehand too, because that one little niche there is somewhat inconsistent with patterns of autism. But more information is needed, and just a deeper conversation can help. Now, this one, in contrast, leans more towards CHR. So Wanda reported daily subtle changes in her physical appearance, which makes it hard for her to recognize herself, especially in mirrors. She's not experienced difficulty recognizing others. This distressing experience began around 2020, coinciding with her depression. In 2021, she covered mirrors with newspaper for about a year to cope, but now avoids mirrors without covering them, worried that there might be a parallel universe hidden in them. Okay, Wanda's difficulty recognizing herself in mirrors, along with the belief that mirrors might hide a parallel universe, points much more towards CHR than autism. The experience had a clear onset, is distressing, and involves unusual thought content, which are all hallmarks of attenuated psychosis symptoms. While self-recognition issues can show up in autism, the presence of delusional thinking and time-like emergence makes CHR the more likely explanation. I will also say that in Wanda's case, these challenges began to emerge sometime around a very salient moment in the history of the world during the pandemic. So perhaps probing more about external events can be useful for Wanda, but also for all of our clients as well. Okay, now this one is a little bit more deep about an overlap between a variety of different potential symptoms and experiences and potential disorders. So let me read this one to you because I feel like this one is more rich and realistic. Michael is a 13-year-old boy born in Vietnam to a mother with serious mental illness and adopted by his current family. His first mental health evaluation was when he was 10. Michael's psychiatric nurse practitioner diagnosed him with attention deficit hyperactivity disorder and autism spectrum disorder. Pragmatic language and syntactic deficits were also noted from an early age. Last year, while in 6th grade, Michael exhibited anxiety and perseverative beliefs. He began talking to himself in his room and using neologisms. A school-based evaluation resulted in educational diagnoses of ADHD and ASD based on social disconnectedness and invading others' personal space. Michael's parents felt something else was going on and sought a second opinion. Considering Michael's history, previous assessments, and their assessment battery, which included a few solid measures and maybe some that have less evidence, the team characterized his current symptoms as attenuated psychosis syndrome or clinical high risk for psychosis. A few months later, clinicians in the psychiatry department confirmed symptoms of functional decline, cognitive disorganization, and hallucinatory experiences. They prescribed him an antipsychotic at that time, but concluded that these symptoms were best explained by post-traumatic stress they inferred from his pre-adoption life. Most recently, Michael was weaned off risperidone to manage a new side effect of tics. He subsequently manifested growing suspiciousness with reactive aggression towards peers for imagined slights and insults that he could swear he heard. A different school contracted psychologist, their reevaluation concluded that a diagnosis of psychosis was warranted based on the several years of unfolding clinical observation. Acting from the supposition that early onset psychosis was too rare and too stigmatizing a condition to apply to a, quote, kid who's just having trouble paying attention, unquote, the first school psychologist remained adamant that ADHD and ASD were the most appropriate diagnoses, and Michael would be ill-served, pumped full of neuroleptics. Okay, I'm going to highlight a few things here in this slide. So you see here, this represents some general issues that many of us have faced in trying to find the best diagnostic and treatment fit for young people experiencing difficulties that could be either in the autism spectrum or emerging psychosis or other disorders like ADHD is peppered in here too. Issues highlighted by this vignette include things like similar symptoms and developmental history for psychosis and ASD, developmental delays, social difficulties, school challenges. Second, differences of opinion among presumably well-meaning treatment team members regarding pros and cons of psychosis diagnoses. And even if psychotic or psychosis may be a best diagnostic fit, some team members were concerned about stigma, and that can, and also the risky side effects of medication, which might have been bubbling up here as well. Additional comorbidities that can complicate the diagnostic picture, like ADHD and trauma, were also prominent in Michael's situation, and the like. So I would also just sort of point out that at one point there was a use of a test with minimal validity. So I'm not sure how much useful information the Rorschach ink blot is going to give the person, and they gave a diagnosis of the attenuated psychosis syndrome without an evidence-based evaluation. So all of these are some of the symptoms that might highlight risk for a variety of different challenges. Now, let's see here. Move on to this slide here. So I'd like more information on his symptoms related to autism. This is sort of like one of the things that I think about when I'm going through vignettes, like what more information do I want to know? And so getting a deeper evaluation would be really helpful for that. And I'd encourage you to just think about these kinds of questions for Michael or for any of your clients. Like, what additional information would you like to know? How could you manage all the discrepant perspectives? How would you approach treatment planning? And maybe 1,000 more questions, leaning into your curiosity, because curiosity and also I think the concept of hope are two of our most powerful tools in supporting others. Yeah. So for me, like I was saying before, I'd like maybe a little bit more depth of an assessment on autism. Plus, they didn't do any structured interviewing for psychosis risk. More about his family situation. I'd like to know how he's doing in school. I'd like to think about his interest, his strengths, being strengths-oriented and client-driven. Maybe whether it has siblings, his sleep. Sleep can be really important. How's his mood been? Anxiety, all sorts of things. For me, treatment planning would start with coordination of his care and his team and a continued curiosity to learn more. Then I would very much weave that information into um, a deeper understanding of the priorities of him and his family. And then we go from there. All right, just a few quick notes on treatment planning. And this is really where the rubber meets the road in terms of how comorbidity impacts decision making. When it comes to treatment, it helps to remember that we're all far more similar than we are different. This perspective, it builds empathy and keeps us grounded in a shared humanity. So treatment, I think, should be driven by the client and often their family as well, when applicable. They're the experts on their own experiences, their own values, and their own goals. Mental health professionals' role, in my belief, is to partner with them, not just guide them. That means truly knowing your client, taking the time to create an individualized approach, building on their strengths, learning what's worked in the past, and understanding what they want for their future. Also, being responsive to their individual needs and the needs of those that surround them in their community. Our interventions need to fit within the client's context, not the other way around. We shouldn't force our interventions and viewpoints on them. In practice, you'll draw from your tool bag. That might include educational supports to help clients stay on track in school or work, or psychoeducational material to help deepen an understanding of their symptoms and the ideas of recovery. Cognitive behavioral therapy to address thoughts and behaviors, social skills, training. This can help strengthen connections and their social network. Family interventions to improve support systems and to help them in their day-to-day functioning, and always a focus on safety so that they're not at risk of death by suicide or hurting themselves in other ways. I think really the best thing to keep in mind with treatment considerations is that the key is flexibility, pulling out the right tools for the right client at the right time. All right, so just a quick example of how our model works and how I train folks in our clinic to address mental health concerns for someone at risk for psychosis. So, as the focus of this talk has been all about comorbidity, it is very rare that someone comes to us and says, Dr. Schiffman, I'm looking for help with my clinical high risk for psychosis symptoms or my attenuated psychosis syndrome. Instead, people come to us and say they're depressed or they're worried or anxious all the time, or they can't pay attention or focus, that they're afraid they're going to lose their job, or they're failing out of school, that they're losing their friends, that they're fighting with their family, that they're not sure where the next meal is going to come from or where they're going to sleep that night. So what we think about is identifying the priorities of the client. And you'll see here on this slide a variety of different examples of mental health or contextual concerns that our clients can bring to the fore, bring into treatment. So what we think about in terms of prioritizing treatment is to understand what are the priorities of the particular client. And I thought I'd give like a, let's see, this flow chart. It's our roadmap for what we consider a modular treatment, and it guides us from first contact to targeted interventions, ensuring that each client gets the right care at the right time. Now, it might look a little overwhelming, but in reality, it's a logical map that's designed to kind of bring order to what could otherwise be a fairly all over the place approach. So we start with assessment, and assessment is followed by safety and risk planning if that's a consideration for your client, which oftentimes is, as we mentioned earlier, suicide's quite common in folks at risk for psychosis. Then we develop an individualized formulation. We get feedback and determine whether psychosis is present. If psychosis is identified, we refer to a first episode team because they can provide the best type of service for someone that's already crossed the threshold for psychosis. If not, we move into treatment planning within the context of our CHRP team, or if you aren't in a CHRP team, using the tools that you have that fit their clinical priorities. Treatment planning, engagement strategies, psychoeducation, all of this while checking in if the client is doing okay and is safe and is also ready to participate. You see the engagement on the slide of that part of the slide. Now, when distress or impairment is present, we decide what's driving it. Attenuated psychosis symptoms, internalizing symptoms, externalizing symptoms, or maybe even transition age concerns. And this is how we've kind of conceptualized a transdiagnostic approach to this. From there, we match them to the right module or the module that seems like the best fit that's driven by their decision-making process. For example, CBT for CHR modules might focus on selective attention, reality testing, or coping skills, all in the service of mitigating some of their clinical high risk for psychosis type of symptoms, like positive and negative symptoms of psychosis. Another example are internalizing modules. These address things like stress tolerance or poor sleep and emotional literacy. We have a category of external modules. These focus on concentration, social skills, and substance use. Transition-aged youth modules support identity formation, problem solving, and relationship building. Now, throughout the process, we can add supports from our tool bag, things like medication management, family therapy, and school or occupational support. The idea here is client-driven, client-focused, and flexibility. The flexibility and the flow lets us respond to changing needs while staying systematic. So treatment is both personalized as well as rooted in evidence-based approaches. Okay, so this is an example of a client that I worked with. I'm smiling because in some ways this was a great success, but there was it started off a little bit tricky because rapport wasn't established as tightly as I would have liked. This client was quite suspicious of me and our services at first. And so we did an assessment first, and you see that that's where everything began. Fortunately, there were no safety concerns for this young person. But we tried to understand what they were going through and what they were reporting to us. And there were some clinical high-risk symptoms that they brought up. Fear of their bedroom being haunted, and there were like monsters under the bed in their closet, and it was interfering with the family functioning because they were like sleeping in the living room, and there wasn't a lot of space in the home, and there was a lot of distress associated with the fear that the room was haunted and there were evil spirits in there. So that was the CHR formulation, but I knew that there was more to it than that. They were talking about skipping school a lot. And mom was concerned about substance use, but client denied. So those were like our beginning individual formulation things. We gave feedback. We talked about what we had heard, and leaning into or emphasizing that the client and his family were the experts on themselves, and that our job was just to help synthesize the information so that we could better understand and partner with them in creating a treatment plan. The client did not meet threshold for psychosis. So we worked together to create a treatment plan within our CHRP clinic and shared some information about psychosis risk and what it might look like, how it's how a person is at increased risk for developing psychosis, but that is not a predestined outcome. And early intervention, as they were engaged in, could be really helpful. You see there box or oval 7, engagement. My client at the beginning was not engaged at all, was reluctant to join, didn't really like to come to sessions, and at first didn't really see much value in our work. So anticipating that, we have certain modules that help with motivation. So you see collaborative goal setting, motivational enhancement, and caregiver collaboration and behavior management. That last box, actually working with the caregiver, got us a foot in the door. So at the time, the client was learning. They had their learner's permit for driving, and so we worked with mom to allow the client to drive to therapy so that at least we could get him in the parking lot. We can always get him out of the car, but we got him to the parking lot with that. And then when we did get him out, I began to learn more of his interests. He wanted to go to college, and he wanted to study psychology. And as a professor of psychology, I had something I could share with him and offer. And then he slowly opened up about his goals. And his primary goal wasn't traditional mental health. He had been assigned to a school for what they called in that region serious emotional disturbances. And he didn't think that he had that. And the school's educational curriculum wasn't as rigorous as he wanted. He thought he was being understimulated and really wanted to go to a good college, and he felt like this school was holding him back academically. So knowing that that was his priority and focusing on what he wanted to work on, I said, give me a try. Let me partner with you, with your mom, and hopefully the school to change your school situation. So that's what we did. The primary, once we got him engaged, primary distress was not around psychosis risk. It was around other factors like school and occupational help, which you'll see in the bottom right there. And we made a plan with his school. We were monitoring his symptoms related to psychosis constantly, but they were sort of at bay or not getting worse. And we made some inroads in school. We had a plan there. He followed through the plan, and eventually he got out of that school and went back to his districted school and did great. Now, meanwhile, other things came up. He was a little overweight, so we worked on health things. That was like his second priority. And then eventually we started working on psychosis risk, and we used things like alternative explanations, reality testing, as well as a little bit of coping for the experiences of being haunted and the monsters in his room, which actually was quite helpful. Another thing that came up was substance use. So he was using cannabis, and had to talk to him about the link between cannabis and psychosis as a comorbid concern that can lead to higher rates of psychosis. So that became something that we worked on as well. And it was a long process, but we did make some inroads. And what I want to emphasize here is that the prioritization of his challenges were not just about CHR. We used skills and tools that would be applicable for any kid that had similar challenges. It just so happened that this young person also had CHR symptoms that we were able to tackle when the time was right, when they became a priority for him. All right, so that was just one way to think about a modular approach to care, where I've created a little map that guides the therapists that I work with. And this kind of leads into a bottom line take home that I have with this, which you don't have to have this map or access to all these tools. You don't have to reinvent the wheel. Just start by figuring out what's driving the problem. Then reach for the tools you already know and trust, that have worked for you in the past and worked for you with other clients. And what tools have worked for the client that you're working with currently? What strategies have been effective for them, even if you haven't been the one implementing them? Keep checking in on psychosis risk symptoms, as well as other very serious comorbid type or associated concerns like suicidality. And if things aren't improving, don't go it alone, right? You can consult or refer. And woven through all of your approaches to care, I believe, should be the concept of kindness. When people feel believed in and that they belong, it can change the whole trajectory of their life, regardless of what particular strategy or approach to care you use. I'll end with this. It wasn't long ago that the idea of identifying people before threshold psychosis wasn't even on the radar. Early identification and early intervention and better outcomes for young people at risk, that's like not ancient history. That's relatively novel stuff. And it's because of this shift in thinking, a shift that you all are a part of, that every skill you bring, every connection you make, every young person you help navigate these signs and the overlap of their mental health concerns and the comorbidity, that's the revolution. We've moved away from a time when no one was looking at early signs of future risk. And we're becoming more sophisticated by understanding that symptoms exist transdiagnostically across categories, so that we can best identify what the root of the issue is and in partnership with our client, and then continue to partner with the client and their family to come up with a treatment strategy or an approach to care that's going to further potentiate their journey towards recovery. So we are part of this revolution, and together we're not just following that change; we're sort of leading it. And with that, I thank you for your attention and your dedication to this topic, and I look forward to hopefully crossing paths again soon.
Thank you for joining us for this session in our Early Psychosis Learning Series. The Tennessee Department of Mental Health and Substance Abuse Services, TDMHSAS, extends gratitude to our collaborating partners, the Tennessee Association of Mental Health Organizations, TAMHO, and Park Center, for their support in bringing this series to life, and to our presenter, Dr. Jason Schiffman, for generously sharing his time, knowledge, and expertise. Thank you again for your commitment to learning and for the vital work you do. We hope you continue to engage with the series and take away insights that support your practice and the young people we serve.